Good evening and welcome all the delegates. Dr. Abhayankar will join shortly.
बोली सकते हाँ
Once again, very good evening and welcome all the delegates. Dr. Abhayankar will join shortly as he is trying to connect. Dr. Shah, can you change your name as we can mention? We can see only doctor here.
Hello.
Yes, sir. Yes, sir. So,
Can you hear
sir,
me?
yes, sir. Yes, sir. Perfectly audible. Kindly change your name, sir, as we can see only doctor mentioned over there, sir.
Name.
Just name, sir.
Okay, okay. So,
Sir, just click on attendance list and click on three vertical dot. You
huh?
will see rename option. Sir, just click on attendance participant icon.
Where it is written?
So bottom there will be, sir, three vertical dot. Technical team, if you can do this rhythm. Technical team.
Hello. Hello.
Yeah, ma'am. If you
Hello.
can change name, Dr. Jain Shah.
Change. Okay.
હે ના છે ને લોગ આઉટ કરવાનું લીવ કરી દઉં અચ્છા 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 હલો ઓ અહીંયા આવજો ને
of the recording. We will start after 2 minutes. Request for kindly stop the recording. We will start after 2 minutes.
Once again, very good evening. All the day. Dr. Bhavesh Patel, you have raised your hand. So,
It is just for attendance.
okay. Thank you, sir. So we'll start in a 2 minute. Dr. Abhayankar is trying to connect. He is facing some technical glitches. That's why it's taking time. But he will join shortly. Sir, before proceeding, I request all the delegates kindly switch on your camera, sir, for a while.
Can you you have sent me the fresh set of slides or not?
Yes, sir. Already shared. Ankit Shah has shared slide.
Where is the slide?
Dr. Shilpa, Dr. Forum, can you switch on your camera?
Okay, shall we start? Going to
Just a minute, sir. Good evening, doctor. Myself Ankit Shah, and today's our topic is MRA, and today's our moderator is Dr. Atul Abhayankar, and a doctor, well-known cardiologist in Surat, and currently doctor practicing at Heart First Cardiac and Vascular Center. And over to you, sir. Thank you so much, sir.
so it is like the previous time. Everybody who is visible on the panel is going to answer questions. So how are we going to proceed? So everybody on the panel will answer, or I will just ask randomly?
Sir, randomly you can take opinion from the experts of MRA, sir.
Okay. So let me share my screen. Okay, my screen visible?
Yes, sir. It's visible, sir.
Just trying to put a slide. So am I in slideshow?
Yes, sir.
And slides are changing, right? Okay. So today basically what we are going to discuss is kind of on a focused topic, and there are few questions that we will address, and anybody who wants to make a comment is welcome. I mean, I feel a little awkward in doing it like some kind of a examiner asking examinees, so we don't want to do that. So I'm going to put forward certain points, but it would be good. It would be more interactive. It would be more interesting if any one of you, or if I don't have to call out names, that is better. But if anyone can take up any of these questions and then talk about or your opinion about your practice, or as we will see the questions, They are more to do with how our practice is at the moment. So let's go with that. So what percentage of heart failure patients approach you in the NYHA 2, 3, and 4, and how many go undiagnosed at an early stage, and why? Second question is, what are the diagnostic and prognostic tools used by any one of you for the heart failure patients? So can anybody would want to just answer? I mean, this is as I said, this is not some kind of exam. This is just opinions of various people. So why do you think that these patients are not diagnosed in time? Anybody can take voluntarily this question? Yeah, Dr. Bhavesh, are you there? Dr. Chintan, Dr. Bhavesh, Dr. Forum, Dr. Saurabh, anybody?
Yes, sir. I just wanted to tell you, most of the heart failure patients who present to us, mostly they are undiagnosed. Primarily, the GPs or the MBBS doctor, or someone who does not does not diagnose the problem, and they directly start some symptomatic treatment for the heart failure. If the patient is suffering from shortness of breath, they start with they give injection steroid and all, and symptomatic management at the moment of time, and they don't generally refer the patient on exact time. And
yeah, you want to say something?
And second thing, the diagnostic and prognostic tools. The most common diagnostic tool which we use in the ICU setup is we go for the echo, and we see the IVC and crepitations, clinically see the crepitations, and anti-proBNP. Most commonly we use this tools for the diagnosis of the heart failure.
Dr. Shilpa raised her hand. So, Dr. Shilpa, you want to say anything? Okay. If anybody else doesn't want to comment, then basically I'll just sort of just cover the rest of this thing. Is that the major problem is that the patients consider dyspnea many times as due to various other reasons. That means many patients, because of age, they consider that because they are not used to exercise. So many times the patient is actually having dyspnea for quite some time, and their quality of life has actually come down, but they tend to attribute it to various other issues, and that's why it kind of goes undiagnosed. So the simplest tool, probably, as was rightly said, is an echocardiogram. So I think the echo is probably the diagnostic test. All that you need is just to demonstrate that the ejection fraction is lower. We are talking of mainly of heart failure, reduced ejection fraction.
Yes.
So HFrEF is diagnosed purely by simple echo. Now, NT-proBNP is not required for diagnosis of left ventricular dysfunction or heart failure. It is but useful in prognosticating. That means it kind of tells you how bad is the current state of heart failure, and in deciding how aggressive treatment should be in some patients. And it is more helpful in acute situations when patient presents to, say, an ICU because of a decompensated failure. Then you can decide about the aggressiveness of treatment and various other aspects, like, for example, revascularization. So many times when patients have very high NT-proBNP, then it is better to delay the procedures like revascularization and then bring the NT-proBNP down first, and then consider doing the bypass surgery or angioplasty. So this is the update of the 2021 update on the 2017 ACC expert consensus for optimization of heart failure treatment. Why did we come to this slide? Okay, so there are certain issues in starting the MRAs, and that is the potassium. When the potassium is higher, or when patient obviously has creatinine more than 2.5 in men and 2 in women, or EGFR which is more than 30. So are these parameters routinely tested before and after initiating MRAs, and then how long they should be tested? Anybody would want to? Yeah, please.
Sir, actually, when we diagnose that patient is in heart failure, patient is having heart failure on 2D core of that, then we'll go for at least basic routine tests like CBC, SGPT, creatinine, and electrolyte levels. So it would be the basic test before we start an MRM. But when it get complicated or some symptoms develop, then and then we repeat it.
Yeah, I mean, I think this kind of very simplistic questions, I don't think that at least as an initial investigation, there will be anybody who will not be doing creatinine and electrolytes as a basic part of investigation. So, but it is just to sort of emphasize the fact that before you start an MRA, it is of course essential that you know the creatinine level, EGFR level, and potassium level, because you don't want to have an untoward side effect rather than helping the patient. The heart failure guideline recommendations for MRAs are that for HFrEF, the MRA is recommended to reduce risk of HHF, that is heart failure hospitalization and death. That is a class 1 recommendation. For mid-range ejection fraction, the MRA may be considered to reduce the risk of heart failure, hospitalization, and death, which is a 2B indication. So, as far as the mid-range is concerned, this thing is 2B, but as far as the reduced ejection fraction is concerned, there is absolutely no doubt this is a class 1 indication. Let me just add to this that although this is a class 2B in mid-range, but actually there are many other trials, many other investigations which have shown us that mid-range ejection fraction heart failure behaves quite like the reduced ejection fraction. Because one thing is that some of them could be the recovered ejection fraction, but even if it is first time, then they tend to behave similar to HFrEF. But they are low risk, so the risk reduction with any treatment also will be slightly lower, because the higher the risk, more will be the benefit demonstratable with any kind of treatment. So looking at just the overview of treatment of HFrEF, we know today that there are 4 or sometimes maybe 5 pillars of treatment, as has been shown here, that which consists of either an ACE inhibitor. Now we probably use lesser and lesser of them for heart failure, because now ARNI is so well established and has shown that it is so much superior to ACE inhibitors, ARBs, that probably ARNI is the most important part. Beta blockers, no doubt, we have been knowing for some time. SGLT2 inhibitors have come into big way in treatment of heart failure, and it has a class effect, but at the same time, the data is largely with DAPA and EMPA, and to some extent with CANA, but some of the other ones are not established. So any proven SGLT2 inhibitor is a part of that. And what we are going to discuss, we are discussing today, is one of the important components in is the MRS. Now, although this is in the guidelines as one of the major pillars of treatment, but if you just look at a lot of prescription for patients with LV dysfunction or heart failure, you will find that many times this is missing. And it is more times missing when there is no diuretic. Because actually speaking, diuretic is not that way an essential component. As you can see in the lower part, that only when there is a volume overload. So diuretics largely help in treating things like dyspnea, which is still persistent, edema fit, So things like that would be helped by diuretics. But diuretics actually do not help in improving outcomes in terms of mortality or even hospitalization for heart failure. So that is why. But when I think I would sort of not hesitate in using some of the maybe commercial names, but some of the drugs, like for example, Tide Plus, Tide Plus. So when it is that plus part, the MRIs get utilized. But when the patient is not receiving any diuretic, many times it is kind of missing from the prescription. So if you are not using any other diuretic, you have to keep in mind that you have to have an MRA on board. So this is just a question, maybe more than one people can answer on that. As to what percentage of patients you use MRAs for heart failure management, and when do you consider in starting with other, that is either an ARNI or beta blocker, etc. So it is not kind of limited necessarily to just one panelist. More than one people can comment on that. So how many people would start? You can just raise hands. How many people start MRAs for every patient of heart failure? So I actually, some of the people have cameras off, so I can't see how many people raise hands. But in any case, so as I was mentioning, that it is very clear that we still don't consider MRAs as much as we pay attention to ARNI or SGLT2 inhibitors. So the most important part or the change in the guidelines or the management is that now you don't have to add drugs one by one unless contraindicated. Unless contraindicated, all four pillars of treatment of heart failure should be initiated simultaneously. That means unless you feel that there is some issue with, like, say, hypotension or potassium or any other thing, that you want to delay the MRA subsequently. But otherwise, all drugs should be started as far as possible, either at the same time or within a short period of time. That means if you are worried that you should all of a sudden start 4 drugs, then in a naive patient, but at least within a week, 10 days, 15 days, all things should be on board. So that is the important part. So let me show some data about the importance of timing of initiation of the mineralocorticoid receptor antagonist. So this is the data. This is, I think the slides are slightly haywire, but this is the data of comparison of spironolactone and eplerenone. So before we go to comparison, let's understand one part, that MRAs also improve the objective parameters of left ventricular function. So if you look at the LV end diastolic volumes, LV dimensions, or ejection fraction. So as you can see here in the left hand part, that there is improvement with spironolactone, there is improvement with eplerenone. But if you want to compare, these are the patients where it was randomized. So this is a randomized comparison. So you can see here that the effect, there are 3 things where there is a statistically significant difference. And that is the diastolic dimensions, the end systolic volume, where you can see that there is a more pronounced effect, and the baseline to 6-month improvement is better with eplerenone. So similarly, the ejection fraction improvement from 34.7 to 38.3 versus 34 to 40. So the improvement is in the range of 3.6% here, where this is 6.2 with eplerenone. So good part is that both improve LV dimensions and improve ejection fraction, but eplerenone in at least this randomized trial, it's not a huge trial, it's only with 224 patients. But if at all there is anything to go by, then there is an evidence that eplerenone actually is better. So is there any specific patient profile where you prefer one over the other? Sorry, let me go back. So anybody? So who prefers eplerenone, who prefers spironolactone? Those who prefer spironolactone can raise their hands. Whatever I can see. Yeah, okay. So why not eplerenone? Yeah, Dr. Saurabh, you
Yes,
raised hand.
sir. Most commonly due to the affording issue, cost of eplerenone is a bit high, on the higher side as compared to spironolactone. The most common thing which we face in the day-to-day basis is the cost. That no other thing is hampering using eplerenone.
Anybody wants to say anything? So I think one of the most important advantage of eplerenone or spironolactone is the gynecomastia issue. So in patient who has had a previous history of say gynecomastia, of course, and is now you want to restart this thing, of course you will start eplerenone. But if you look at the data, I mean, as the data I showed you, it's not like huge data. I mean, it's only a small trial, but there is probably a reason to prefer eplerenone. This is not something like a gospel truth, but we tend to, if you ask me, many times we tend to use spironolactone more out of habit because we have been using it for a long time, for many years, and eplerenone is relatively new, and so therefore we tend to use spironolactone more often. But definitely in terms of gynecomastia, there is no doubt that eplerenone does not have that problem, and we should actively think about starting eplerenone rather than purely by habit start spironolactone. So I think this is a very busy slide, so I think I will not read out everything in the slide. But basically, this is to suggest that one has to look at potassium, and up to say 4 to 5.4, that means up to 5.4, you do not need any kind of dose adjustment for that. So you can step up the dose if the potassium is not increasing, it is less than 4. If you need to, you can step up the dose. But once the potassium goes to 5.5 and above, and then you have to decrease the dose. So from 50, you decrease to 25, 25 to 25 alternate day. So I think this is not some rocket science. It is very clear that if you have anything up to 5.9, you adjust the dose. Anything if it is more than 6, then you stop the MRA and then you wait till the potassium comes down, for which you use standard methods of reducing potassium and then reintroduce the MRA once it has come down. So let me talk about the hyperkalemia issue as we were discussing. I mean, we discussed about hyperkalemia before, but let me. So, what is the true? Because the concern that everybody has in giving MRA is patients who already have slightly higher potassium. And what is the true incidence of hyperkalemia? So, these are all the trials. These are the post-MI trials. These are the heart failure trials. So if you look at the data, the incidence of hyperkalemia is kind of variable. And it was one of the highest to the tune of something like 20% in the RALS trial. Whereas if you look at some of the other trials, it was pretty low. But if you look at what is the extra, that means even placebo group caused hyperkalemia, because the overall pathology profile of the patient is also going to cause hyperkalemia. So if you look at actually how much was the excess hyperkalemia, which was true contribution of an MRA to hyperkalemia, then only 54% were truly related to MRA. So the concern that the MRA will have hyperkalemia incidence in a very high proportion is not true. So it is sort of 9.3 was the actual incidence. But if you let compare to placebo, then it was only half of that. So something like 4.5, 4.7% was actually true increase in hyperkalemia in these patients. So we already saw in the previous slide what percentage of heart failure patients on MRAs develop that. And we also saw whether we discontinue the treatment. So that slide also we have seen. So the next part that is very interesting is what is the timing of eplerenone initiation. Now, if you look at this trial, this was a fairly large trial with 6,632 patients, where after an MI, between 3 to 14 days of that MI, the treatment with eplerenone was started. Now, these patients were divided between those where the treatment was started in less than 7 days and then between 7 to 14 days. So less than 7 days and more than 7 days. So if you look at the outcomes, then the early initiation of eplerenone, that is in less than 7 days, reduced the risk of all-cause mortality and also the risk of cardiovascular hospitalization and cardiovascular mortality quite significantly, and also the incidence of sudden cardiac death. So this is a graphical representation and very clear message that the earlier administration of eplerenone, this is in relation to post-MI heart failure, improved outcomes and also the dimensions. But there was a 31% reduction in all-cause mortality. So you can see that it came in the graphical manner that early eplerenone did the best. But more importantly, the reduction in the sudden cardiac death, because the incidence of sudden cardiac death also would be more common in the early period. So incidence of sudden cardiac death was significantly lowered by starting eplerenone in the early period. So earlier you started eplerenone, you actually gave more benefit. So this is a very important message. Not only that we should not ignore MRIs, eplerenone is marginally better, that the incidence of hyperkalemia is not that alarmingly concerning, but the early initiation actually is better. So this coming back to our algorithm that we should start with an MRA and we should reserve the loop diuretic for only for fluid retention. That means either because now the patient is having pulmonary congestion, patient has weight gain, patient has edema. So these are the situations where you give the combination. So as a routine, as many people are used to, do not start that combination of torsemide or furosemide with MRA, but give MRA as a primary treatment and add the furosemide or any of the loop diuretics only when you have the reason for fluid overload causing symptoms. That I think I have already discussed at what stage of heart failure diuretics and MRAs both are needed. And what is the preferred choice out of these combinations. So I think we already discussed about why eplerenone may be preferable. So nothing more to discuss about that. So anybody want to ask any questions? Anybody want to pass any comments about how you use this in your practice, and what should be done to increase awareness of usage of MRAs in practice? Screen. So anybody wants to ask any question, pass any comment? Yeah, please.
Sir, how frequently we have to monitor after starting eplerenone electrolytes?
To some extent, it will depend on the patient's stability. That means if patient is very stable heart failure, not very grossly symptomatic, then probably initially once in a month, and then later on once in 2 to 3 months is good enough. Because once you have established that there is no hyperkalemia. But when the patient is just come out of ICU, when the patient is in early period, then The second subset where you would monitor potassium more frequently is those who already have a reduced EGRF. So if they have a reduced EGRF, then you would monitor them more frequently.
Hello, sir. Good evening. Dr. Chintan here.
Yes.
Sir, I would like to ask about the HEPF. So on echo, which are the points we look for the HEPF, and we can diagnose or we can label HEPF through echo?
You're saying heart failure with preserved ejection fraction? Is that?
Yes.
Yeah. Okay. So the diagnosis of HFpEF requires a couple of things. One, either a demonstration of increased diastolic pressure, that means diastolic dysfunction, or the clear-cut diagnostic this thing is antiprobion. So when you have somebody with a normal ejection fraction or even supernormal ejection fraction, but you have other things to suggest for the possibility. That means you have left ventricular hypertrophy, patient is hypertensive. So the commonest association is with hypertension. But there are also other these things like hypertrophic cardiomyopathy, any other types of hypertrophy of left ventricle. So in these situations, so a clinical scenario and then NT-proBNP elevated in presence of normal or near normal ejection fraction. That would be diagnostic of HFpEF. Of course, there are other methods where you can do even invasive monitoring to establish with Swan-Ganz that the diastolic pressures are or wedge pressure is elevated, but that's not necessary. I mean, for common clinical practice, just demonstration of either significantly elevated diastolic pressure and or elevated NT-proBNP is good enough.
So is there any significance of TR in HEPF?
Significance of? Sorry.
TR for HEPF. Is there any correlation of TR in case of echo to diagnose HEPF?
TR, yes. I'm sure you are asking about tricuspid regurgit.
Yes.
Yeah, I mean,
any significance of that?
No. If pulmonary artery pressure is elevated and you have a secondary TR, then of course that would be a part. But it's not necessary. I mean, every HFpEF will not necessarily have elevated pulmonary systolic arterial pressure. TR depends on systolic pulmonary artery pressure. So it does not necessarily depend on pulmonary capillary wedge pressure. So pulmonary capillary wedge pressure elevation is required for HFpEF. But pulmonary artery systolic pressure elevation is not necessarily it's not necessary for diagnosis.
Okay. So what will be the NT-proBNP level in that cases?
NT-proBNP levels for any kind of heart failure that are accepted are with atrial fibrillation more than 900, without atrial fibrillation more than 600, and suspicious more than 400.
Okay.
So many of these HFpEF might have atrial fibrillation. So the level then would be 900. So Ankit, if there are no more questions.
Yes, sir. Just a few minutes, sir. Thanks for Dr. Kiran Dalal from Baroda, Dr. Saurabh Daseda from Ankleshwar, Dr. Jaimin Shah from Baroda, Dr. Foram Patel from Pardi, Dr. Chintan Patel from Valsad, and Dr. Bhavesh Patel from Vapi, Dr. Jayanto Shah from Surat, and Dr. Shilpa Suttaria from Surat. And big thank you to Mr. Atul Abhayankar, today's our captain. And thank you so much for such a wonderful session, sir.
Thank you.
Thank you so much, sir. Have a wonderful session, sir.
Once again, thank you all the delegates and the moderator for such a wonderful discussion. Thank you.
Thank you.